Yeah. Okay. Assalamualaikum and good morning, everyone. So today we are very lucky to have Dr. Wan Asyraf Zaidi to be with us to deliver a talk about neurovascular anatomy in stroke. So we have been friends for about how many years? 10 years, I guess. So I'm very proud of what he has become today. So he obtained his master's in HUKM, and subsequently he pursued his interest in becoming a neurologist. And currently he is, I would say, among the most active stroke neurologists in Malaysia. So apart from establishing the stroke pathway in Malaysia, he's also actively doing it, helping other countries to achieve this stroke pathway protocol in other countries such as Philippines, Indonesia, and he has been selected as the future leader for the World Stroke Organization, if I'm not mistaken, right? So, well, if you go for any stroke conferences, the conference is not complete without him. So, without further ado, I would like to invite Dr. Wan Asyraf to deliver his talk today, and I hope that he can benefit a lot of us. Thank you.
Okay, Assalamualaikum. Very good morning. Thank you, Dr. Nasrina, for the kind introduction, and thank you for the invitation to share call regarding this topic today, neurovascular anatomy in stroke. This is actually maybe a few days or maybe a whole program on its own, but I try to make it a bit more simple, and I hope we can be interactive if possible, because I think the best is actually face-to-face for this, but unfortunately because of the current circumstances, they're a bit difficult for us to do this face-to-face. And just call me Asyraf, and I'm one of the stroke neurologists in UKM. I start, and just stop me if you have any question. Okay, I hope you can unmute yourself and ask question then. So disclosure, none for this talk. So objective, very simple, to understand stroke clinical diagnosis. It's a clinical diagnosis, at least you know, I need to emphasize on that. It's not based on scan, it's a clinical diagnosis. And learn some skills. Today, maybe it's a bit more exposure, and I choose something that you can use in the emergency department. So neurovascular anatomy related to acronym called BFAST. I'm sure majority of you know BFAST. I was told that at least in the ACLS you have FAST, and paramedics also doing that. And I think BFAST in certain training center. And we will try to go through together a large stroke and interesting stroke syndrome. And call mentioned over there as a physician. So I'm talking to emergency physician. Maybe there's also intern over here. You are going to be a physician in majority of the time, whether emergency physician or internal medicine physician or neurologist yourself. And you require skills. So basically from med school, no just teaching alone like this will help you, and book alone will help you. There's none, but actually training, and we need to get adequate history and examine the patient ourselves. So in short, the patient is your book, and hopefully after this session, you can try to see whether you actually you already experienced this before. Okay, so if you're looking at the updated definition of stroke, so this is by Prof. Sakwat and the group, published in 2013. So in short, basically, stroke is clinical diagnosis of sudden neurological deficit. Most of the time, they are negative symptoms. Maybe I just give you a bit of example. Negative symptoms are mostly weakness, for example. So they have called motor deficit, complaining of arm weakness or leg weakness, facial drooping, something like that, and or loss of sensation. Yeah, so those are negative symptoms. However, positive symptoms rarely can be happening in stroke, especially in the ICH, intracerebral hemorrhage. They can develop seizure, movement disorder, jerky myoclonic movement. Okay, so those are all pain. So those are positive symptoms. And they are still neurological deficit. And these neurological deficits the etiology must be vascular in origin, okay, and it can be in large group, basically occlusion, okay, whether this is because of stenosis, thrombosis, cardioembolic, artery to artery embolic, or hemorrhage. So hemorrhage can be because of intracerebral hemorrhage, AVM, called CCF, there's a fistula, or can be because of cerebral venous thrombosis. Yeah, so those can lead to hemorrhage. Those are all true. If it lead to a tissue infarction, so there is a cell death, neuronal death, then it is a stroke. If it's no infarction, maybe this is what we call as largely, if you join us before in the previous lecture in the neuroemergency, called special interest group, then I have discussed about TIA, so transient ischemic attack. This is found by Prof. Charles Miller Fisher. Okay, and maybe I'll just introduce to you, rather than telling transient ischemic attack, not against Prof. Miller Fisher, he's a very legendary neurologist. Threatened stroke is just to basically make sure that the message being delivered to the public, they actually have a stroke. So they shouldn't allow a completed stroke, threatened stroke. Okay. So going to my next slide is basically something that's not new. Susan Arrow in 2017 published in Stroke, so about BFAST. So if you notice during the recent Malaysia Stroke Council and also World Stroke Organization launching of World Stroke Day this year, 29th of October, we decided in Malaysia to use BFAST. In bahasa, we then translate it to permata, selamatkan permata hati anda. Yeah. So the reason being is because of BFAST is basically acronym including posterior circulation. And from the publication by Susan Arrow, you can also notice that it actually pick up a bit more extensive, more patient, about 14% more patient with a stroke, and majority that they're detecting now will be the posterior circulation. So B stands for balance, E basically eyesight, F is face drooping or numbness, arm weakness or numbness, speech disturbance, whether this is dysphasia, I'm talking to doctors, I'm using a bit of medical terms, and also slurring of speech or dysarthria. And T is time, basically pick up the phone, preferably we want to ask the patient to call the ambulance, 999. We know this is a problem during this COVID pandemics, but we want the patient to come early to the hospital. In the recent campaign, we decided to basically tell the public to arrive to the hospital within the first hour from the stroke symptom onset. Okay, any questions so far? None? Okay. So again, this is something that I learned from our colleague, Dr. Chow, from Hospitals Brangjaya. So hi boss, actually, HIBOSSES, okay, SES. So lots of bosses over there. So you need to know that you need to take a bit of brief history, even in hyperacute. Hyperacute means within the first 24 hours. Then acute within the first 7 days. And after that is called subacute and chronic. Okay, so history is there. You need to know blood pressure assessment, onset of stroke if you're playing around with the called hyperacute, mostly whether it's wake up stroke also, definite onset, wake up stroke, unsure onset, sugar. So we don't want to treat as a stroke. If this were to be stroke mimic, for example, hypoglycemia, severity, depending on in which group of healthcare professional we are talking about. For example, we can talk about BFAST with paramedic and FAST ED. Both that have been done in HUKM. I think we have called Jessica before with us, and also Isra. I think Jessica is in HKL, emergency physician, and also FAST ED is being done by Isra now in Serdang. Okay, and I think I also welcome physicians, including emergency physicians, called the registrars in emergency department, internal medicine physician, to learn about to do NIHS or maybe modify NIHS score. Okay, this is a validated tools, all of them, to assess stroke. And then at least you have the same wavelength. It's like GCS when we discuss. And the last one is, if you assess a stroke, you need to know how to read a scan. So going to my topic today, after a lengthy opening just now, again, history exam as clinician, that's why it's very important for me to go to emergency physician, internal medicine physician, and obviously neurologists. All of them need to know how to diagnose a stroke. And this is, I think, something that not new to all of you. It's a revision in majority, I'm sure. So you need to know where is the vascular territory. So we have from this picture, the yellow color over here is the ACA territory. Okay, the red color here, majority of the time the stroke will happen with this area. This is a MCA territory. Okay, MCA is red over here. Okay, and we have the one at the blue area over here. This is the PCA territory. Okay, so actually in this picture maybe a bit more than usual. So this area over here, if you see my cursor, I hope you can see my cursor. That is basically the area of called sharing between MCA and ACA, and this is MCA and PCA, and this we call as watershed area. Yeah, so this is our external watershed. We will then hopefully have time to go to the the imaging anatomy later on for the internal watershed, because of this is just at the level of basal ganglia. And if you look at the purple color over there, the subcortical, the cortical is the one that just now MCA, that's gray matter. When I tell you about cortical, it's about the gray matter over there, which is mostly at according to the territory. But the gray matter in the middle part is what called as subcortical. This is being supplied by the lenticulostriate arteries. It can be the medial, which is coming from the ACA, and the lateral lenticulostriate arteries actually coming from the MCA. And we have also a bit at the called the lateral geniculate body and the posterior limb of internal capsule coming from the ICA, which is the anterior caudal artery. Okay. So this is actually famous picture every time you look at the anatomy, but yeah, maybe it's not really immediately representative of the usual imaging, but roughly this is anterior circulation, the MCA coming from the ICA. ACA, this is the main branch that you can do thrombectomy. Afterwards, this is not evidence-based. This is ACOM. Okay, ACOM. After the ACOM is basically no longer A1. This is A1, the main branch of the ACA. A2 afterwards, yeah? And A3 and A4. MCA over here, we'll try to look at the anatomy later on. And this is the posterior communicating artery. In a certain patient, they don't have posterior communicating artery. And posterior communicating artery, I suppose, is easier to remember, is coming from the ICA. Okay? That is the anterior circulation. The posterior circulation is vertebral artery, right and left. It produces the pica, posterior inferior cerebellar artery, and the anterospinal artery supplying the spinal cord. Okay. Then this one, after the merging of the vertebral artery, become the basilar artery origin. This one a bit larger. This will call as ICA, anterior inferior cerebellar artery. Okay. And from there, it can be coming from the basilar or coming from the ICA, the internal auditory artery, or the labyrinthine artery also be there, coming from the ICA. Then you have the pontine perforators, which is coming from the basilar itself. We have a picture on that, we discuss later. Superior cerebellar artery to supply the midbrain and also the superior part of the cerebellum. And the PCA, again, as part of midbrain, thalamus, and also the PCA, as you can see over there. Okay. Any questions so far? Nothing in the chat. You can put in the chat if you're shy. Okay. So now we're going to the one that I selected based on the BFAST. So because of, as I mentioned to you, if I go to all the anatomy, it can be very, very, very lengthy and very, very heavy. So at least we have a few of message and some of the things that we can discuss. So balance in the called acronym of BFAST is basically referred to vertigo. Rarely they are in isolation. If they are in isolation, I would say it's a bit difficult for you to diagnose a stroke, but it can still be a stroke. Yeah. So this is a picture you can see. I hope you can see this. And can anyone shout in the chat or at least unmute yourself? Where is the structure? The arrow, the white arrow over here, actually showing to the anyone in the room. Yeah, so there's some. Okay, so that is okay. Nasrina, medical, medullary infarct, medial. Okay. Anyone else? Okay, maybe still early in the morning, so no one really in the chat, or I can see just now, yeah, somebody driving or miss it still listening. So this is actually the lateral part of the medulla. So this is a medulla. Okay, I agree with Dr. Nasrina. There's a bit of extension to the medial medulla. So looking at this, so this is most likely called T2 imaging. You can see the T2 flare because of the CSF is being suppressed. And you can see that called the gray matter is basically part of the gray matter, which is only here. And called, you can see suppression mostly of the CSF. And you can see very nice called hyperintensity at the medulla. Okay, this is the lateral medulla, a bit of going to the medial part. Okay, so in majority of the time, this is actually a picture of a lateral medullary, and I have given you the answer over there. This neurovascular, right? So this is basically being supplied by the posterior inferior cerebral artery. Okay. Can anyone tell me in lateral medullary syndrome what is the name and what are the clinical symptoms? No one want to try? You can unmute yourself. Yeah, okay, Dr. Nasrina have been very interactive. Okay, so basically this is what we call as Wallenberg or lateral medullary syndrome. Yeah. Okay, so I will go to the one that Dr. Nasrina mentioned. So this is supplied by the posterior inferior cerebral artery. Next slides. Okay, so actually this is the front part of the medulla. This is anterior and this is the posterior. Okay, so as you can see, called Nasrina is mentioning about the spinocerebellar is all about you can see the one on the lateral part is basically the spinocerebellar tract. So maybe I'll just put it in reverse. So the thing is, if you look into just now, I'll just go back a bit to the picture. You can see the anterior part of the medulla is not affected. And what is actually there? Because of we go with the BFAST, right? There is arm weakness and there's weakness, right? So this is the this is called the cortical spinal tract. In the medulla, we call it as pyramids. Pyramids, cortical spinal tract. Pyramids contain your motor fiber to move. Okay, so the pyramids decussates, called at the inferior part of the medulla. So anything above from the superior part of the medulla will cause still a cross-signed weakness. Okay, so for example, if the medulla, the superior medulla is affected, cortical spinal tract, the weakness will be on the other side. But obviously in lateral medullary syndrome, the middle part of the anterior middle part, which the cortical spinal tract is there, is not affected. That's the reason why in lateral medullary syndrome, there is no arm weakness, okay, and there's no called lower limb weakness in a pure lateral medullary syndrome, okay. And as mentioned by Dr. Nasrina just now, so basically you can have a cerebellar signs. There's no weakness, but cerebellar sign because of the spinocerebellar tract is affected, which is in the this part. So we go back to make life a bit easier for you. So the lateral part, okay? You can have ipsilateral facial numbness because of that is being supplied by the cranial nerve 5, right? The trigeminal, right? So ipsilateral to the stroke, you have numbness, no weakness, and then contralateral numbness, okay? Because of the lateral spinal thalamic tract. So the spinal thalamic tract is here. The spinal thalamic tract is not being given here. So, but it's actually at the lateral part of the medulla. Okay. So you can see if you understand this anatomy, and just now, if for example, it go to the middle part, it go to really medial, you have a patient with medial medullary syndrome. You can see this is usually supplied by the anterior spinal called anterior spinal artery just now, and this area is basically will then cause a clumsy tongue. You can also have called pseudobulbar, which is upper motor neuron lesions, okay, of your bulbar called cranial nerve. So then they are called also can cause the vagal nerve involvement, yeah, the vagus nerve involvement. Your vocal cord will be paralyzed. So it's actually a very bad stroke. So even though you can see medulla is very, very small, but it is packed with all the importance, eloquence, called vitals, nuclei, and tracts. So that's the reason why it can lead to the medial medulla specifically can lead to a very life-threatening and even lead to death. Okay. So now the vascular part, just now you learned about posterior inferior cerebral artery and also the anterior spinal artery. In majority of the time, you just need a P2 flare. Your DWI will be positive anyway because of this is and a bit difficult for you because of this is a very vascular area. Okay. Any questions so far? Okay, so just to show to you, this is called CTA of the patient, of a different patient, but I'll try to make sure that, for example, you do MRI and that's why you need to have a clinical examination. You have lots of vertigo there. You can see there is nystagmus according to Wallenberg syndrome. Okay, fulfill the criteria, most likely called medullary syndrome. Okay, in this case, maybe there is a called very bad called hypoglossal lesion on this side. Then you know that the imaging is not shocking, and the MRA, for example, will be like this. Yeah, because of MRA, TOF especially, the time of flight is using our own blood supply, and as a contrast. So you will see the stump like that. So you don't know whether there's a clot or whether there's a stenosis. Okay, the first imaging when the patient arrives can be something like this because of your protocol is basically without a called a vascular called assessment. Then you decided when the patient become very bad, now become drowsy. See, pica supplied the inferior part of the cerebellum. So this is inferior cerebellum. You can see now my cursor, right? So and called the cerebellum, this large area of called this is a DWI called going to be infarcted. It can still be something like this, okay, which is the flares, nothing there. Then you are saying about the DWI flare mismatch, which mostly you need to know the full criteria. In this case, it's already more than 50% of the area from DWI. This is not within the usual wake up called flare mismatch model, yeah. Okay, and using a TOF, you overestimate, you don't know, and you cannot predict this to come later on. So basically, that's the reason why if you attended my talk before, so I would say a baseline, at least a CT scan, okay, clinical assessment, history, exam, full field posterior escalation. CTA shows a stump or a stenosis over there on this side. You may see a bit better compared to this MRA. Yeah, and you will then can able to predict this to come to you. Yeah, so clinical assessment is very important. It's not about MRI or not. Okay. Any question with this? Understand what I want to show. This is maybe upon presentation. This is the final outcome. And anyone can basically tell us why we need to know this at baseline, why we need to predict this from happening. We may not be able to prevent this. Maybe we're able to put a stent in certain patient, but it's not evidence-based. Yeah, correct. International again. So we want to prevent herniation. For example, like you keep the BP slightly higher by allowing more perfusion. You allow generous blood pressure. If hemoglobin is low, you want to give it a bit more help to you transfuse the patient. You basically monitor them closely. So if there is signs of worsening of the cerebellar stroke, you want to refer for posterior decompression. And this is one of the most rewarding one. They can survive and they can still be alive, and functional. At least a bit more compared to the anticoagulation, certain patient. Okay, so that's evidence-based. So that's why we want to have that. So if there is radiology fraternity people over here, so that's the reason why we need a vascular imaging immediately. At least it's scan plane and CTA. So yeah, this one, for example, if you have a CTA, then you can see the whole thing. This is MRA, yeah, and this is a CTA. You can see the thrombus inside. Okay, it's gonna be too long over there. For the B and the I side now, patient acute visual loss on the right side. Something coming from the right side, the patient cannot really see, and patient complain of there is a bit of weakness on the right side of the body too. History done, I already told you, but yeah, it's very, very brief. So something may be happening on the left side of the cerebral cortex because the patient apparently looks a bit confused, and I'll show you other tricks. Blood pressure is okay, 150/90, onset within 2 hours, sugar okay, 6 millimole, not hypoglycemic, not even ring a bell for DKA or HHS. Severity, you can use fast ED, but in this case, I give you NIHS, which is 17. Scan, this is the plain scan. Is it too fast? Okay, so where do you want me to stop? I'm sure you know by now, the first two is actually from posterior circulation. Okay, let's start with the lower part here. Anything you see? Nothing over there. Look for ICH because of CT scan plane. No. Okay. So, and we go to basically the pons. Okay. And you look at the other part. I can because of there's a note over here. This is a fully functional trial version, but actually the occipital lobe also is good, and this is common. Look for anterior circulation also concurrent stroke. Okay. So I'll just stop here for a few minutes, and can you see now this patient basically? I just go back to the history and elaborate a bit more. Okay, so basically this patient had acute right-sided right-sided homonymous hemianopia. Okay, and this patient basically neglecting the right side of the body, but yeah, it seems to be weak on the upper limb and the lower limb with no facial weakness. It will not be shocking if you will see the other imaging later on. This is acute stroke because of there is occlusion. It can be still normotensive, but in majority, because of there is called blood flow limitation. So flow, okay, is directly proportionate to your blood pressure and inversely proportionate to your blood vessel resistance. Okay, so blood pressure went high, sugar is okay, so that's not the cause for the thrombosis potentially. And when we wait for the ECG to come and also palpate for the pulse, actually this patient had atrial fibrillation. Okay, this is a thick slice, so you cannot see the dense vessel sign. So now, knowing that this is homonymous hemianopia, from the vascular imaging, we are talking about neurovascular today. Which vessel you want to look for? Just now is basically right-sided, right? So you want to look something at the left. You can see something there on the left, MCA, right? But this is, yeah, being a clinician, you know, the MCA is not the one that you're worried, right? Okay, and some more the power is there, but it's still in the mostly neglect. Yeah, so as expected, Jacob, thank you for highlighting left MCA. Maybe something is there, but again, history and clinical examination. Yes, we need to look at that. I'll just tell you that there is a, looks like there is a bleeding vessels over there. Actually, there's no clot. Looks from here, looks like something over there, but it's not. You see there, there's a stump. This is the left PCA. Okay, and this is the stump of the left PCA. This is actually not fair for all of you, I know, because of this is one slice. When we look at hyperacute imaging, we go through all the images. But for the sake of today lecture, to just trigger the interest and the reason why that we need a vascular imaging, neurovascular assessment, then this is really help you. So this is left PCA thrombus. NIHS is 17. So you know that this is P1 still. So this is indication for thrombolysis or thrombectomy. Oops, why Dr. Nasrina seems to be shocked? You want to share your thoughts? You still have time, right? Okay, yeah, correct. So basically, yeah, I called as what you asked me to do today. Obviously, I share with you. Yeah, in HUKM, this is luxury, I suppose. I didn't I was trained in this, and but I can just share with you. Obviously, because of in Malaysia, we still have lacking number of called stroke physicians. We need emergency physician, internal medicine physician, geriatrician, or even a neurologist to really know how to assess stroke immediately. If I have more people knows how to read vascular imaging, CT perfusion might not be something of interest. Okay, but with this CT perfusion, I only use this less than 10 seconds. You know that this is a left PCA stroke. This is PCA territory just now, right? Remember the image before? So this is time to pick. Okay, this is not setting for CT perfusion. Just to show to you, this is basically there's a delay of blood flow over here. Okay, otherwise, just to share it with you, this is a very good scan if you want to thrombect or thrombolize. But this patient basically come outside of hours. Postural circulation is not validated for CT perfusion analysis. And we know during this time around, this patient come within office hour, just end of office hour at 5 o'clock. So we activate thrombectomy, and this patient NHS after 24-48 hours too. Okay, from 17. Okay, so that's not the things that I want to share today. Just to trigger again interest, you can come to our hospital to learn more about that. Eyesight, basically, you need to know this. Okay, this is again, it's a lecture on its own. So you need to know about the neuroanatomy, called anatomy of the optic nerve, optic chiasm, optic tract, optic radiation, the visual cortex. So you see just now the CT perfusion, you know that the lesion is over there. This is concurring with the right-sided homonymous hemianopia, left-sided cortical lesions on the occipital, on the visual cortex. As you can see over here just now, for those that missed the first picture, that's a visual cortex, okay? And you can get this lecture, you don't need to write any notes, yeah? So I think this also accessible. You can see it's actually something I take from the geekymedics.com. So you see macular sparing, so patient basically can see you when you're in the middle. But in acute stroke, bear in mind, and hyperacute stroke, I will show to you there will be a bit of other things can happen because of this cortical stroke. Patient can have, if you notice, I'll just share the image of the CT scan plane. Yeah, this one maybe you cannot see, but actually the eyeball is actually deviated to the left, just to show to you, look at the left brain. Okay, you can see the lens actually, they're giving the clue. Oh, if this is too big. Okay, maybe next one. Okay, so these are the possibility. You can have monoocular. Bear in mind, actually, there is evidence for hyperacute CRAO treatment now, other than just massage. So you want to see whether this is CRAO or whether this is basically maybe related to the optic nerve. Okay, monoocular. Bitemporal hemianopia, optic chiasm. It can be also something like called pituitary tumor, everything that called it's a bit skewed to the lateral part of the called this optic chiasm optic nerve. So then you can have this lesion, okay, nasal heminopia, and then optic radiation, okay, and then and subsequently then you see that the visual cortex. So then homonymous hemianopia, usually you need to know, for example, temporal lobe is superior, temporal lobe is inferior, so there will be superior quadrantonopia. Parietal lobe is basically called superior, then the inferior quadrantonopia. Usually they are incongruous because of the they are the optic radiations lesion. Okay. Okay, so now we already finished BE, so we are going to phase arm, FA. Okay, we're going to finish soon, hopefully. So in this case, anyone can basically tell me on the left side here, the R image and right on the side and left as usual CT scan. There's a, I already put there this image. You can have a look. So what do you think? Which artery is involved and what structure is involved over there? Okay, so basically, this is, yeah, good. So the Nasrina again, I suppose. Okay, okay. So, yeah, so basically, this is what I call as the basal ganglia. Okay, so you can see the trigon there on the normal side. Inferior part of the, I call the basal ganglia, there is called hypodensity. So this is being supplied by, yeah, the lentiform nucleus. Dr. Chow is around, okay. So, and this hypodensity, usually most commonly, this subcortical stroke again, the middle part, this is actually being supplied by, blood supply is by the called lenticularis artery, okay? And the reason why I put this picture, this is from Stanford Medicine, you can Google it up. So this is this is the internal capsule. So just you can see over here, 70% of the cortical spinal tract, yeah, actually go through at the end, mostly at the anterior part of the internal capsule. Okay, a bit spread, but it then there is a bit of bundle, which is a bit more dense at the posterior limbs, and at the posterior limbs is the sensory fiber. Okay, so anterior part, you can see from the anterior part where they can be more anterior leg, trunk, arm, the genu, then you have a bit of face and maybe your bulba. And that's why this atria can happen over there. And if we go to posterior, it can be a bit more dense because of the 70% of the cortical spinal tract is there. So that's why it becomes hemiplegia. The front bit, hemiparesis, the posterior bit, hemiplegia, and worsen because of there is also sensory fiber. Okay, so by knowing that, for example, if it were to be involved over here, you know that, yeah, the sensory fiber is affected. It's not a thalamus lesion, but the sensory fiber is there. That's why patient had hemisensory loss and hemiplegia. Okay, and the one I want to show to you over here from this picture, you can see this is what I call as the homunculus. Okay. Okay, so you have the inverted body, so the face, called the tongue, the larynx, tongue, lips. Okay, nasal area, eyelid, neck, thumb. So the arm, they call the hand and arm here. Then the trunk, then the middle part, which is the hip, knee, ankle, and toes. Okay. Next slide. So the picture over here just to show to you that the caudate nucleus and the anterior limb of internal capsule is different lenticular artery. It's coming from the ACA here. This is the lenticular artery. It's like a very small roots of a 16 rambut baby. Yeah? Okay, and I call this is a bit. This is the picture. Actually, maybe need to invert a bit. Sorry. So this is the called just now the basal ganglia, the lentiform nucleus, yeah, and the internal capsule just now can go from the genu and then to the posterior part. This is coming from the MCA. Usually, the lenticular artery from MCA is coming from the end of the MCA. Okay, and actually, this one is the most likely lenticular artery. Okay, Okay, obviously they can overlap. Yeah, so ACA, MCA lenticular striate. Okay, and this one, it can be occluded because of, anyone can tell me the diagnosis? You can have it occluded because of these small vessels is already suffering a chronic progressive lipohyalinosis. And you know the lipohyalinosis happen because of hypertension. Yeah. And if you have a called atheroma over here at the wall, which you cannot see because of you need to do autopsy for that. This is the when you do a DSA or angiogram, you actually only the luminal anatomy. You cannot see the called the fat layer outside, like called autopsy. So what you need to basically postulate, if there is called stenosis over there, maybe it already called going inside to the lumen, okay, to the intima and media, and you know that it can obstruct this lenticular striate artery. We call it as branch arteriomatous disease. Okay, maybe that's homework for this time around, branch arteriomatous disease. Okay, and it's not clot related over here. Obviously, you can get stenosis of the main vessels. This is the main highway. This is maybe your called Luraya Utara Selatan. This is within KL, like Aceh, Suka Duka. Okay, but this one is your Jalan Rumah. Yeah, still very important, right? Okay. Anyone, any question over there? So you can see if, for example, this lesion, internal capsule, okay, or caudate nucleus. So internal capsule first, so you then understand why they have hemiparesis. Okay, why it involves the posterior left hemisensory loss. Without thalamus, or with thalamus can cause hemisensory loss. And sometimes this area, hypertensive, uncontrolled sugar, it can come with positive symptoms, hemichoria, right? So if you then see there is a lesion at the vessels, you'll not be too shocked, right? Yeah, that's what we call a neurovascular assessment. Okay, that is related to the face and arm in the BFAST. Okay, we're going to the last one because of T is telephone. And before, if you have time, to the syndrome, clinical syndrome, which I intend to show to you because of emergency department, obviously we'll see speech. So yeah, I will not share the full slides this time around, but anyone want to shout the diagnosis? This patient come with right side of the body weakness, unable to produce any speech. Left MCA, okay? And correlating with the clinical diagnosis this time around, left MCA. There's a stump over there, there's a clot over there. But you see there's a called dilatation of the vessels. This is very scary. It's aneurysmal throughout, even posterior circulation, okay? This is related to uncontrolled hypertension for sometimes. Correct, it's Broca area involved, most likely. Okay, so, but can you have aphasia with this? Where's this now? Okay, because of time, maybe I just shout. This is the pons, okay? And obviously just now, if you extend up, then from the pyramid just now, this is the anterior. So it's still the pyramids there. So this is cortical spinal tract. There will be right-sided hemiparesis too. This patient also can be aphasic because of mostly unable to control all the articulant called muscles to speak for speech. Yeah. In the initial phase, if it were not to be related to this, then the patient can be, for example, hypertensive in nature. Usually is more sharp edge. In this case, when you have DAR like this, this is the DWI like this, you need a vascular assessment. Boom, something like this happen. You know that if the patient come with low NIHS, you'll not be too shocked because of NIHS. I didn't put up the NIHS system around. Maybe then during the workshop for acute stroke, we can discuss. NIHS representative more of anterior circulation, and it represent more the area which speech or dominant lobe. Yeah, but in this case, posterior circulation is not called being represented well. So, and you know that I told you just now, with Dala just now, good collateral supply. I want to show to you, this is the blood supply. This is the basilar artery cross-section, basilar artery, the short circumferential and the long circumferential coming from the basilar artery. Okay, so you have the paramedian vessels perforators. Okay, from the circumferential arteries, you have the perforators coming in. Okay, so the hypertension seems to be called sharp edge because of it's actually related to the perforators. It's something like your lenticular right artery just now, but for when you have a thrombus over here, so it will become a bit something like this. Then obviously over time, when the clot already clogged the whole system, then you have DCS drop. Okay, that's not something shocking. And yeah, if you delay, you didn't manage to achieve this, then the outcome is death. Okay, so for those who cannot remember and recall a bit, just to show to you the left MCA just now, the left side, okay, Broca. This is the inferior frontal, just the Broca. And the Wernicke actually at the temporal lobe. Okay, this is both being supplied by the MCA. And that's called a communication fiber, arcuate fasciculus. Also, it can be affected by a stroke in the MCA territory. Okay, so we're going to this a bit of fast ED, eye deviation over there. You can see the eye give a clue as the stroke. Why is that so? This is not a video. And this is the next scan above the this ganglion level. You can see the stroke is happening. Okay, this is not a video. Okay. And this one is the upper part of the called the axial view. I just want to show to you again. Do you know what structure is this? This sulcus over here. Look for this. Yeah, good. So the Tunasina, I suppose, or the child. So okay, so remember the omega, but sometimes it's already disappeared because of previous stroke. Yeah, but in this case still there. But this is a very distorted omega already. This is the omega, but this is actually sulcus, which is the central sulcus. This is the primary motor cortex. You can see it's hypodense, so it's not shocking that the patient had right-sided hemiplegia. Okay, and again, we are talking about neurovascular assessment. This is MCA territory. Okay, other than knowing about the motor cortex, this is central cortex over there. Anything in front to the central sulcus is basically the frontal lobe, and this at this level, this is the parietal lobe. Okay. Okay, so and this patient basically had a perfusion scan. Obviously, again, I can tell you, if you have this, look at the vessels, these main vessels, MCA, and IHS was 20 plus. So this is one with the left MCA clot. Okay, so the things I want to show to you, malignant MCA stroke, Kernohan syndrome. So this picture basically is called SDH patient, but I changed it to MCA stroke to make it a bit easier. So when you have MCA stroke just now, large stroke most of the time if the proximal or ICA, and then this ACA, MCA. So you know that called Monroe-Kelly doctrine, skull is rigid structure. Increase in the brain matter, CSF, or the blood flow is associated with increased ICP. Its rigid structure also being limited with the falx cerebri and tentorium cerebelli, right? This separates between left and right, and also between the cerebral cortex to the posterior fossa, right? Okay, what I mean by the Kernohan syndrome is basically as the ICP increase. So if you have the cortical spinal tract lesion just now, you have cross sign, right? So the face is weak on the other side. This is left, so right-sided facial weakness, right upper limb hemiplegia and lower limb hemiplegia, but basically be upgoing over there. The GCS can be dropped because of this dominant lobe, okay, the verbal component in the GCS, right? And obviously the motor you can still use on the other side. But Kernohan notch happen means that as the ICP increase, inferior medial, so then because of the tentorium cerebelli over here, part of your cerebral peduncle of the midbrain, which contain your cortical spinal tract over there, is being called compressed. Yeah, cortical spinal tract over here. Okay, going through the cerebral peduncle, tentorium cerebelli. This notch over here is called a Kernohan notch. It compressed this other side, there's no stroke over here, but because ICP increase, compress this cortical spinal tract, now you have ipsilateral to the stroke side, Babinski up and weakness. It becomes something like called quadriparesis, yeah, because of the ICP increase and the coronary notch already being compressed. Obviously, as the ICP increase inferior, you have the third nerve from the midbrain going out anteriorly, being compressed at the ipsilateral, sluggish initially, and become dilated. ICP increase further, brainstem being compressed, the contralateral called oculomotor nerve, which is the third nerve, then also compromised. You get the Cushing reflex, bilateral, called pupillary dilatation. Okay, so to explain the gaze deviation, you need to understand this. In normal circumstances, from the frontal eye field, okay, Boltzmann area 6, okay, will then stimulated on the left. It will go to the paramedian pontine cranial nerve 6, okay, on the right eye, causing the lateral rectus to abduct the eye. Okay, so this is looking to the right. Okay, abduction, cranial nerve 6. Very fast forward. Okay, you cannot see the movement lagging, because if it's lagging, there is a lesion through the MLF. Okay, on the left, medial longitudinal fasciculus, the third nerve is being stimulated, so the eye will then go to the medial side. This is medial rectus. Okay, so that's why then this is normal called activation, and the eye is actually looking both to the right side. Imagine if there is a stroke, okay, you lost homeostasis, so basically eye can look at the primary gaze central. So that's the reason why in the stroke, large stroke, it will go to the, in this picture, cortical stroke, it go to the lesion side. You cannot see anything at the cortex, large enough. You still need to look at the posterior circulation, right? Understanding the pathway just now, you can get the slides, then basically it's still posterior circulation, not safe. Maybe it's not a stroke because of the Putrajaya like HUKM, your primary center, you have all the stroke mimic coming in. So it can be a seizure. So seizure activation, if you're fortunate enough, so it's stimulation based on the theory just now, you have a stimulation. So yeah, you then have a gaze to the stimulations, away from the stimulation side. Okay, in short, usually this also about 15 or 20 minutes on its own. So just to show to you a bit of things that you are seeing every day and to explain what you are seeing every day. Okay, I open up to question. Where am I in terms of timing now? Oh, okay, that's nice, 1 hour.
Okay, Ashraf, is that the end of your presentation?
Yeah, for today.
Okay,
so
all
I
right.
hope that's not heavy. Is it heavy?
Yeah, I think it will be a bit heavy lah. All right, so thank you so much for sharing all the nice cases. I think don't be stressed out if you do not really understand about this. It seems easy for Dr. Ashraf. He has been doing it for quite some time. But even for me, I took about 2 months for me to really understand and master this topic. Even though I'm not good at it, but at least I do understand a bit what you have a gaze deviation to the right or to the left, and where is the lesion. It takes quite some time, so don't be stressed out. It will come slowly for you to digest it. So I would like to open to the floor to ask Dr. Wan Ashraf about any questions, burning questions that you may have in encountering your daily clinical practice cases that you would like to bring up today. Ada ke? Okay, if you tak ada, okay Ashraf, I have few questions to ask you. I was being asked by one of my MOs recently that since you touched about malignant MCA infarct, what is the ideal BP control for this population? As we all know that this kind of diagnosis is not eligible for thrombolytic therapy because of high risk of bleeding. and you would want to monitor and manage the BP well. But unfortunately, if you look into various guidelines, they only put more of the hyperosmolar therapy should be given to the patient, and neurosurgical consult should be obtained as fast as possible. So while waiting for this, how do you advise the BP control should be? Because we know if the BP, if we bring the BP down, there is a possibility that the ischemia might go further. But at the same time, you also do not want the cerebral perfusion pressure to go up high because of the already high ICP that the brain is suffering from. So what is your take on this?
Okay, so basically, in short, the answer for that is there's no randomized control trial which is proven to be beneficial at the moment. For example, like when you play around with osmotic called therapeutic therapy, which is the mannitol you're talking about, right? In certain called population with, I think there's another few agent we try to play around to to change the one called cerebral perfusion pressure. As I hinted out to you just now about flow associated with pressure divided by resistance. So all those things there's a called clinical trial experiments or called research to look into that. But at the moment, there's not majority unproven to be beneficial as a standalone treatment. So for example, like called in this case that I'm now scrolling, you can see this is more than 1/3 MCA. So in the scenario, I want to know what is the vessels that occluded. I'll just make it fast. The scenario that been given by Dr. Nasrina just now. So there is occlusion of the MCA. So in the hyperacute situation, it's very clear. For example, in our case, it's a bit easier again. Boom, the CBV is low. You can see very nice red over here. You can see my screen, right? So yeah. Over there. So this is MCA stroke. There's occlusion, NHS 20. This patient belongs to the indication of standby for cranectomy. Okay, but you need to understand the list of cranectomy indication. Age more than 60 is not being tested in a lot of series. In the clinical trial, extension, there's still benefit in selected patient. But this is already going to the next one, more than 8, called cross 80. So you need to look at the biological age. So one thing, hemicranectomy is one of the things that maybe you want to discuss. So if you have such image like this, with the CTA positive for occlusion, already have the established stroke, which is more than the 1/3 MCA. Okay, I'll just show to you the CT scan because of the majority of the time, this is the most important thing that you need to know, right? So this CT scan, okay, you can see there is MCA stroke over there. Maybe I'll just show to you a bit of a trick. Custom window. Now, can you see a bit better?
Yes.
Yeah, so with this 40-40 window, then you see it's more than 1/3 MCA. This patient is not wrong for you to stand by neurosurgery called referral. And in fact, from this one, now you see the dense vessel sign. That's the MCA being dense. There's a clot over there. So such patient will progress and will deteriorate. Okay, so then at baseline, when the patient arrived, less than few hours, you already decided that cranectomy consult need to be done. If the surgeon says, and if the whole team, the whole network, neurologist or internal medicine physician, even the EPs or neurosurgeon says, okay, this is KIV cranectomy, then the consensus now, the osmotic called therapy may need to be given. So mannitol as bridging. There's more and more data on bridging. Okay, obviously then you don't want to hyperventilate. You give too much of oxygen, vasoconstriction. So then less blood supply, more edema. And also just now about blood pressure. You don't want to reduce the blood pressure too much. There's a clot. Okay, so you're a bit more generous. Anything less than 180 at the moment, but this not based on randomized control trial. Bear in mind, Malaysia Stroke Society of Hypertension says 220, 120. But we know with this kind of vessels, 220, 120 can cause maybe vasospasm. Yep. Then further causing deterioration. Again, this is based on our clinical knowledge, but not based on evidence. Okay, so BP, mannitol, knowing your patients. So those things, I think at the moment I can share with you in short. Yeah, all the other clinical trial, maybe we can do it in a call, in a more lengthy discussion.
Yeah, thank you very much, Ashraf, because I think malignant MCA, in fact, is not very high in prevalence, but when it does happen, it does have a very high mortality, right? Okay, so we have one question from Prof. Farid. Thank you, Prof, for joining. So people usually interchangeably use dense hemiplegia and dense hemiparesis, which I think it is wrong. So what is your take on this?
So maybe they are influenced with the dense versus sign. I'm not too sure. So basically, Prof. Farid is correct. So basically, hemiplegia, we usually refer for the power which is 0 most of the time, maybe 1, very bad. So anything more than that is hemiparesis. So we don't call it dense hemiparesis. Yeah, there's a bit of a wrong interpretation. For example, like this is 3 a.m. in the morning, then if you, depending on cases, you have like 30 years old, dense hemiparesis. I listen to the dense, then I wake up. So maybe, but oh, hemiparesis, what do you mean by dense hemiparesis? So yeah, but dense hemiplegia, obviously, yeah, called, they are more debilitated. Less power, 0 most of the time. Anything more than 1, then yeah, it's basically usually hemiparesis. Yeah.
Okay.
Yeah.
So in a way, it's how we convey to other people. But I always believe that if you want to communicate effectively with other team, you have to use the right term so that both parties can connect together and basically have that kind of a message to be conveyed clearly. So do we have any further questions? Because we already hit 10 o'clock, and I think if we do not have any, I would like to thank everyone for joining Dr. Ashraf's session today. And thank you, Ashraf, for giving a bit of your precious time. I know you're very busy. And inshallah, we'll look forward to have a subsequent session with you. All right. And if those of you or your friends miss this lecture, I will record it as usual and put it in the Neuro Emergency SIG Facebook group, as well as upload it in the YouTube. So thank you very much, Ashraf. And thank you, everyone. Have a good day. Bye.
Okay, take care. Assalamualaikum.
Salam.
Welcome, Prof.